In this ASCO meeting, we organized a very interesting educational session that was emerging therapies for upper gastrointestinal malignancy. And in this session was very interesting because we tried to make an educative work for the audience, trying to address, since the translational research in gastric cancer and also esophageal cancer, and then try to summarize what we have today in terms of target therapies, what trials we had that was positive, what trials was negative, and also from that trials that was negative, we tried to analyze what we could learn for the future trials in terms of a selection of biomarkers, selection of patients, and selection of target combinations to improve the outcomes in the near future. Another thing that was very interesting that we addressed at that session was some topics regarding immunotherapy. Immunotherapy, as you know, is the cornerstone of many types of tumors, like lung cancer, melanoma, urothelial cancer. So you have today pembrolizumab that is approved in Europe, United States, and also in Brazil as well to treat several types of cancers. We have nivolumab and other types of immunocheckpoint inhibitors that are coming and faster in the new scenario today. Well, with respect to the gastric cancer, we addressed in gastric and esophageal cancer, we addressed initially in our section the whole of some biomarkers like BRCA biomarker, like ATM biomarker, like HER2 as well, and also some techniques that you can use to assess and to address these biomarkers, for example, NGS sequence. We also raised in the section that today it's very important and it's mandatory to assess HER2 biomarker for every advanced gastric cancer that we have in our practice if it has an ECOG PS1 until 2 or 0, so you can address these biomarkers in order to optimize the treatment and add trastuzumab if actually it's pertinent to this type of patients. Apart of that, we discussed ATM biomarker and olaparib, right? Because ATM biomarker negative patients was initially assessed for patients with gastric cancer and found that olaparib could have a good hold at this type of patients, but unfortunately these were results of a phase 2 trial, phase 2 39 trial that show actually some results in terms of the overall survival, but in the phase 3 trial, GOLD trial, unfortunately these results was not actually significant. But despite of that, we discussed in that session that the results was not significant, but some issues could be improved probably for a new trial in terms of how can we assess ATM in this type of patients, and what kind of other biomarkers you can assess to see if olaparib or not actually have a result in terms of overall survival for this type of patient. And this biomarker could be, for example, BRCA mutation. We know very well that is a predictive biomarker for olaparib in other type of tumors, like, for example, ovarian tumors. And also we could try to put it in the clinical practice for EG junction and gastric cancer as well. So another type of biomarkers we discussed was biomarkers that were involved in the resistance of immunocheckpoints like MDM2, JAK1 and 2. So that was really discussed, and I think it could come for the clinical practice in the near future. In terms of immunotherapy, we know that gastric cancer has a very high tumor burden mutation rate, especially in that patients that are MSI high. So these are some types of some subsets of patients that could respond very well to immunocheckpoints like pembrolizumab, according to some phase 2 trials that we have. And probably in the near future, tumor mutation burden could have a place as well in advanced gastric cancer to help us to select patients or tailor treatment in the best way of the practice. In terms of overall take-home message, We know that today gastric cancer is still a challenging disease. It's a disease with a very high heterogeneity. So in terms of molecular classification, we have different patterns among the distinct areas in the world. The Hispanic and Latin American people is not well studied in this type of classification. So we need to focus our research in trying to find out the profile of the TCGCA classification in Hispanic patients as well, because we have very high incident areas in Latin America and also in the United States with Hispanic patients as well. So we should to focus on this research. We should also to understand better other biomarkers and incorporate in the clinical practice to select better the immunocheckpoints inhibitors and try to acquire a better results in this type of patients. And also we should to try to find out good combinations of, or the best combinations of immunocheckpoints and also target drugs that could improve the outcomes in the clinical trials as well. So in the end, I think gastric cancer is a very difficult disease to treat. It's a very heterogeneity. We still do not have too many weapons to treat that, but the things are going very fast and the scenario will change in the near future.